Hello, everyone. Thank you all for joining today. Welcome to our Crisis Systems for All, leveraging data to assess outcomes across populations and planning your community crisis system approach webinar session. Before we get started, I wanted to take a moment to ensure that everyone in the audience is ready and comfortable with any of the technical aspects of the webinar. So as you will see, closed captioning is enabled for today's webinar. We also have American Sign Language capabilities enabled in this meeting. And you can activate that by clicking the interpretation icon on your Zoom navigation bar. If for any reason you may need tech support during today's webinar, please send me a chat message and we'll try to address it for you. And lastly, if you have any questions during the presentation, you can feel free to enter them in the chat, and we will try to address as many of them as we can today. To test out to make sure the chat is working, but also just to see who we have here today, go ahead and use the chat and let us know where you're joining us from. What state are you from? City, organization, what region? We're so happy to have you all here today. The Oregon's here. Hi, Brian from New Hampshire. Hi, Cindy from Arizona. Hello from Kentucky, Department of Medicaid Services. Hi, Bonnie from Florida. Leanne from Utah. Maryland here. Great. Iowa's here. Hello. Ken- Kentucky, Maryland, San Diego, Nevada. Welcome. Welcome. We're so happy to have you all. Alaska. We love to see our colleagues from Alaska, Wisconsin. Nice. Um, so again, welcome. We're so happy to have you here. We're going to talk a bit about, again, thinking about leveraging data to assess outcomes across the populations and really begin to plan your approach to ensuring that crisis systems are available for all members of your community. So go ahead and advance the slide, please. I do, as we get started, want to make a disclaimer that the views expressed in written conference materials or in publications and by the speakers and moderators here today do not necessarily reflect the official policies of the Department of Health and Human Services, nor does it reflect, nor does the mention of any trade names, commercial practices, or organizations imply any endorsements by the U.S. government. Next slide. Today's webinar is hosted by SAMHSA's 988 Crisis Systems Response Training and Technical Assistance Center. We call it the TTAC affectionately for short. We provide training and technical assistance supports to states, territories, tribal organizations, and community organizations across the 988 Suicide and Crisis Lifeline and Crisis Continuum of Care. Along with our partners at W2 Consulting Corporation and Change Matrix, we have extensive experience in crisis services as well as technical assistance. And the TTAC was formed to support the continued growth of the 988 Lifeline and also to build a more robust crisis care system. And the goal of our TTAC is to support crisis care system that is integrated, sustainable, and aligned with evidence-based and evidence-informed practices. And what we do, in addition to putting on great webinars like this, we also offer direct technical assistance to support organizations, states, agencies that just might need a little support in a variety of things, such as developing, implementing, refining, scaling, or even evaluating their services, as well as supporting your workforce and their wellness and workflows and many other topics. So I do want to be clear that we offer technical support and we want you to reach out for it. We work closely with TA recipients to understand their specific needs, even if you don't know what to ask. And we meet you directly where you are and work side by side with you to meet your goals. So we do encourage you to reach out, even if it's just to explore how we could help. And so we're going to include a link in the chat for our TA services. It's not just technical support. We can support you in a variety of ways. Please reach out. We will be happy to welcome you and help you think through enhancing your crisis services. Next slide. I do want to acknowledge our wonderful SAMHSA team. First, we have Dr. John Palmieri, who's the Senior Medical Advisor at SAMHSA and is currently serving as the Deputy Director of 988 in the Behavioral Health Crisis Coordinating Office at SAMHSA. And he has deep subject matter expertise and policy leaderships in areas around crisis response, suicide prevention interventions, care integration, telehealth implementation, and crisis diversion programs. Thank you again to Dr. Palmieri for all of your great leadership. Next slide. And we also have Jill Mays, who is the Division Director of our Crisis System Transformation for 988. And she leads the evolutionary and collaborative work of the Crisis Services TTAC, as well as the leadership around the 988 Behavioral Health Crisis Continuum. Thank you, Jill. And then we also have, next slide, Dr. Laura House, who is the External Engagement and Capacity Building Lead for 988 and the Behavioral Health Crisis Coordinating Office. She is the Senior Advisor to 988 and the Behavioral Health Crisis Coordinating Office Senior Leadership, and also often provides great deep subject matter expertise on strategic engagement efforts and advancing capacity building efforts across the crisis continuum. We're so happy to have the support and guidance from Dr. House as well. Next slide. All right, so welcome to our Crisis Services for All webinar. We plan to share information on how to leverage data to ensure crisis services are available and accessible to all members of the community and produce the intended outcomes for everyone. In summary, we plan to touch on the importance as well as some strategies to assess outcomes across populations. The first step in improving crisis services outcomes is to gather data that represents the full spectrum of our community and the communities within your states and regions. This helps you understand not only the overall trends, but also how different groups within your community are faring in terms of access to care, resource utilization, and outcomes. Data should highlight where outcomes might diverge, and you will use your data to identify where and how outcomes are different for each group. And then develop targeted interventions and resources to close those gaps, and again, improve outcomes for everyone. Once your opportunities are identified, you will be able to develop that tailored approach to address issues related to improving access, utilization, and outcomes for your community based on community-based solutions and also data-driven solutions, including thinking about mechanisms for your funding approach. Tailored strategies work well with strong partners. So we'll spend time during our webinar series discussing key partners to consider partnering with, including community organizations, local governments, schools, faith-based groups, and others that have direct connections to communities you're serving. These partnerships can help expedite your strategy and extend the reach of your services, making for a more impactful and potential sustainable solution. Then you reach back to your measurement strategy to determine your progress. If you have a strong plan for leveraging data at the outset of your endeavor, you'll be well positioned to measure your progress along the way. And so this is how we plan to set up this series of webinars around crisis services for all. And We want invite you all to come and join our webinar series, and this is the first of several of the webinars in our series. Next slide. In summary, we plan to cover 3 points in this series. The first, which we'll be talking about today, is the value of using data to assess outcomes and plan your approach, strategies for planning your approach, and key partners to build coalitions with to enhance your approach. Next slide. So again, just to highlight today, we're going to cover the value and importance of data, and we'll provide an example of a strategy to identify and address gaps within the crisis care infrastructures in different communities. And I'm excited to share with you our guest speakers that will help cover some of these topics. Next slide. Just to walk through quickly some of the objectives that we'll be going through. We'll describe how data can be used to assess crisis services access, quality, and outcomes across different population groups and communities. We'll also address strategies to find and address service gaps for populations in which crisis services may not have been able to reach or may not have been as responsive to as we had anticipated. And then we'll also cover applying a community-informed data approach to strengthen the planning and delivery of a responsive behavioral health coordinated system of care. Next slide. So we've started with some welcome and introductions. It's so good to see a variety of folks online from different parts of the country and representing a broad set of services along the crisis services continuum. We're also going to we're going to have a topic and a guest speaker that's going to cover leveraging data to assess and plan for your crisis services within your communities. We'll also have, again, the example, which is going to be focused on crisis intercept mapping. We'll have some time to exchange information and have a Q&A with our guest speakers and some of our subject matter experts on the line. And then at the end of the webinar, we'll have some office hours to allow you to interact with our Training and Technical Assistance Center, think about any questions that you may have, and ways that we can support you all. Next slide. We have a poll to kick us off. It's, again, great to see all the variety of places that you're calling in from, but we'd like for you to share which pillar of the crisis system do you work in? Do you focus on making sure individuals have someone to call, such as call centers? Do you focus on ensuring that someone is available to respond, for example, mobile crisis response? Do you focus on making sure that individuals have a safe place for help when they need it? For example, a crisis stabilization center or something similar in that pillar. What best describes your work as well? Like, what's your role in your day-to-day? We'll give folks a little bit of time to fill in that poll. And as I'm doing that, I'm just going to look through again to see where we're coming from. I see Texas here, Pennsylvania, New York. Thank you all for joining. Kansas as well. Happy to have you all here. California. Oh, I hear you, Michelle. Brand new program, so you're wearing many hats. Congratulations on launching a program, and thank you for all the work that you're doing. All right, we'll wrap up the poll in a second. Great. So we have folks from a nice mix. Folks from someone to call, someone to respond, and a safe place for help. Great. And I think what we'll be covering will be relevant to all pillars. And so we're happy to have you all here again. Next slide. So I am pleased to have our first guest speaker here today, Ms. Carrie Slatton Hodges. Carrie is the executive director of the Nashville Research Institute. Prior to this role, Carrie served as the commissioner and deputy commissioner of the Oklahoma Department of Mental Health and Substance Abuse Services for 15 years, where she ensured that addressing all mental health and substance use issues remain a top priority for Oklahomans. She's also been the senior behavioral health program director at the National Association for Mental Health Program Directors, as well as served on the board of directors and named NASDAQ's recipient of State Services Award. Carrie has hands-on experience and an administrative track record for supporting states to deliver transformative treatment and support services throughout strategic public and private partnerships, and have a lifelong commitment to ensuring that programs provide opportunities for those with mental health and addiction needs to support them living a full life in the community of their choice. We are so grateful to have Carrie's expertise in this space and to talk about how data can move this, using data can help move this work forward. Thank you for being here, Carrie.
Thank you so much for having me. It's such a pleasure to be here and visit with all of you. I also want to share, when I was looking at the roles that you're playing, that I have been on a mobile crisis team. I've done assessments at a crisis unit, and I've overseen a crisis unit before. So crisis services are near and dear to my heart, and it's such a pleasure to be here today to talk about those with you. So we go on to the next slide, please. So one of the things my main point today is to stress to you the incredible importance of data. Data should and is hopefully a part of each and everything that we do in our work, and all of you play an important role in data collection, whether you are working specifically with a person in crisis and you're inputting data or information about that service, or whether you're someone that's determining what data is important to collect and how to collect it. It is so incredibly important. And if you can take that away with you, I will be so pleased. So next slide, please. So some of the reasons that data is incredibly important, one is for quality improvement. And when we think about our crisis system and a comprehensive crisis system of care, in reality, it's still in its infancy. And so for us as behavioral health folks across the nation, to understand what is working best, understand areas where improvement could be gained, understand where areas are working really well that we can transfer that knowledge, then we have to understand what it is that we're doing in order to continue to improve our system over and over, to have the very best system that we possibly can across cities, states, and across the nation. Next slide, please. And it's also incredibly important in terms of payer accountability. As we're building this crisis continuum of care across the nation, and in your hometown, there are persons that are making decisions about investments in this. And we've seen a lot of investment at city level, state level, federal level. And so it's incredibly important for us to collect the data around what we are doing so that we can ensure that folks that are making decisions about investments are seeing the return on the dollar for their investments, but also so that our system continue to grow and to have the gaps needed filled where there is an area that we have found works well and we need further investment in. So for accountability in terms of the dollars that are being invested, it's incredibly important. Next slide, please. So I want to give you an example of the use of data. and how it can be so important. So when you look at the big green bar on top, that is 100 calls into a contact center. So this is someone to call, and this is 100 contacts. This is actually real data. This comes from Arizona, who does a great job of data collection around their crisis system. And when you look at this, you can see of the calls that came in, of the 100 calls that came in, 21.76, or basically 22%, had a mobile crisis dispatch. So you have two data points here, right? You have the number of calls coming in, and you have mobile crisis dispatch. Then when you look at those mobile crisis dispatch, it's important that they collected data about what was the disposition of that mobile crisis dispatch. And you can see here that 4.2 went to a crisis stabilization unit. 1.6 was an other category, and 1.09 required a law enforcement dispatch. So basically, out of 22, the vast majority, the mobile crisis team intervention, was able to resolve the crisis that was at hand. So when you couple that with the number of calls that were resolved on the line and the number of calls that were resolved through mobile crisis dispatch, you can see that an incredible amount of people who are in crisis are having their crisis resolved between those two issues. But if you go a step further in data collection and you look at the crisis stabilization unit, the 4.2 out of the original 100 that went on to a crisis stabilization unit, there is data collection around what happened with those folks. Well, the vast majority resolved their crisis at the crisis stabilization unit, with only a tiny amount needing to go onto an emergency department. So that was perhaps someone who got to the crisis stabilization unit and was found to have a physical health reason that overrode the behavioral health emergency and needed to get immediate hospital level care. So they went on to an emergency department. 0.67% of those people, if you can look and see, ended up going on further to a psych hospital or detox. That's an amazing amount of people who had their crises resolved in our crisis continuum of care between contact center, mobile crisis dispatch, and crisis stabilization unit. And if you'll remember, those are the three pillars of the crisis system. So out of 100 people, by far the vast majority, 98 point something percent here, had their crisis resolved between those three pillars of the crisis system. Now, we know that, in this case from Arizona, because of the data collection that they had at each one of these intervals. So you could be doing fantastic work, but if you're not collecting these data points, you're not able to show folks the amazing work that you're doing. But this is a beautiful example of the crisis continuum at work and doing exactly what it was designed to do. So next slide, please. Now, one of the things when we look at information such as what we just saw, there are other financial considerations that you can pull from that data to help make your case for why it is important to have a crisis continuum of care and why the investment in that is important. So, for example, if we go back for just a second to that prior slide, you can take one piece of this and look, and you see that within this crisis continuum of care and this data, just slightly just this one little tiny percent had a law enforcement dispatch. So you could actually do a return on investment analysis on this to show that without 988, without mobile crisis teams, without a place to go, it is likely, and you could compare it to data before those pillars were in place, that law enforcement dispatch would have been much greater. And that law enforcement dispatch comes with a financial price as well as a humanitarian price. And so this is another way that data can be used to show the importance of the work that you're doing and the cost savings that come from the work that you're doing. If you take one more little data point here, such as folks going on to an emergency room, well, we know that emergency room visits are costly. And this shows a very small number of people that come through these pillars go to an emergency room visit. So that is a cost savings that can be articulated when you're collecting the data in this manner. So if you'll go 2 slides forward now. So this is just an idea to show you across the nation, for those who submitted data, the number of clients that were served by mobile crisis teams. As you can see, it varies anything from 50,000 and above to up to 2,500, with states varying across the board. Now, if you go to the next slide, one more, please. You can see funding that has gone in for crisis stabilization units. So when you take data around, and go back one, please. When you take data around the capacity that has been built thus far and funding that has been put into those systems, you can start to make a correlation between investment and growth of your crisis continuum and how incredibly important that is. You also can use data like we just showed when you look at the number of persons that have been served by a mobile crisis team by state to compare. When you look at SAMHSA's ideal crisis system, you can see that where you are at as a state in terms of per capita, per number of mobile crisis response, how close you're getting to the ideal standards that are out there that we all aspire to meet, but we're all in the process of trying to get there. So it helps to benchmark across the nation, or you individually as a state, to other states, to be able to say, where am I at in the crisis continuum, and how are we as a state building that information? So go forward, please. And again, I'll point out a little bit more. This shows the investments that have been made for crisis stabilization services across the nation. As you can see, it varies greatly. So we still have a ways to go in terms of building our crisis system. But as you can see, investments have been great, fantastic in many areas. We were looking at data around Arizona. If you look at Arizona, they are one of the largest investments that have been made across the nation. So it stands to reason that they would have great pillars stood up and that they're able to collect great data around that. Next slide, please. Another opportunity for when data is collected and analyzed that is so incredibly important is when a state is talking to, or even as a provider system, talking to the legislatures in your state or nationally to be able to truly tell the story of what is happening across the nation and in the field. It's one thing to say, wow, crisis services are great and we need further investment. But when you have the data to support that this is making a difference in people's lives, it's preventing them from going to psychiatric hospitalizations, which we know have longer lengths of stay, it's preventing emergency room visits, it's taking it's keeping law enforcement on the street for other things while we're handling behavioral health crises. Those are the types of things that are important to be able to share, and one of the reasons why data collection is so important. Next slide, please. So I just wanted to give you an idea of the growth in crisis system, again, looking at data from 2022 to 2024. The orange on the left is individuals served in 2024 in each of these services, and the blue is 2022. So you can see there's been a huge growth thanks to all of the work that you are doing. We've seen growth in crisis stabilization, growth in mobile crisis teams, growth in crisis contact centers, and growth in 988 lifeline centers. If you look to the right, you can see that that corresponds with investment as well. The funding for these services has increased across the board for these services from 2022 to today. Again, use of data to show when investment has been made, the system is growing. Next slide. So as you look at some of this data, I wanted to share with you that you can go to the nri-inc.org website, where you will find reports that populate some of this information that you're looking at. You can look at national summary reports, like some of them that I showed you, and you can also, if you have a login portal through your state mental health authority, you can look at individual state reports. Now, I'll tell you, there are some public-facing reports right now that you might find of interest around the crisis system. There are the use of information technology in crisis system, what mobile crisis teams look like across the nation right now, including the makeup of those, whether they're 24/7 or not, in much more detail, and an overview of the overall crisis continuum of care and how that has changed. So I encourage you to go to that website, and as we go along, I will put that link in the chat for you. But that's where you will find the information that we talked about today. Next slide, please. So in summary, I just wanted to give you some examples of why data collection is so important. And when we think about crisis, every point in the crisis continuum is an important data element, whether it be a call received, whether it be a referral made, whether it be whether mobile crisis was dispatched, the disposition of that, whether a person made it to a crisis stabilization unit, the disposition after that crisis stabilization unit visit. And then you can get into more detail of data in where folks have been doing more sophisticated work to find out how many of those referrals had follow-up and follow through so that people are less likely to go into crisis again in the future. So again, these are all elements that are important to collect, both for our being able to continually improve the work that we do, to learn more about what works and learn more about what isn't having an impact. It's also, again, incredibly important so that folks that are investing in the system understand the return on that investment. So with that, we'll move on to the next slide. This is my contact information, and there's the website that I mentioned where you would have access to public facing crisis reports from the work that we have been doing. And next slide, please.
Thank you so much.
Next,
Karen.
we get to turn it over to Dr. Brett Harris. I'm very excited to introduce her, although I will turn it back to Jasmine to give you a little more background.
Yes. Thank you so much, Carrie. That was fantastic and is really helpful to hear you shared the importance of using data and the variety of benefits of the use of data when we're thinking about our crisis services and crisis systems. And if you all have any questions that you might have for Carrie, please put them in the chat, and we do have a Q&A session where we'll be able to address those as well. I am pleased to introduce Dr. Brett Harris next. Dr. Harris is a senior research scientist in the public health department at NORC at the University of Chicago. She's also the president of New York State Public Health Association and a clinical associate professor at the University at Albany College of Integrated Health Sciences. Throughout Dr. Harris's career, she specialized in behavioral health with 16 years of experience of development, implementation, and evaluation of substance use and suicide prevention initiatives. Dr. Harris leads a suicide prevention portfolio funded by SAMHSA and CDC, as well as some private foundations and organizations. And that work includes focus on a variety of populations within communities, which makes Brett's next presentation really valuable to how we're thinking about our crisis systems and ensuring that services are available for all. Thank you again, Dr. Harris, and welcome. And we're happy to hear from you today.
Great. Thank you so much, Jasmine. And I appreciate the invitation to speak during this session. So I think if we can just get the introduction slides up. And I'll just kind of kick this off by explaining that this particular, what I'm presenting on right now is a way to access data from a process that's already happened. So there's valuable information through crisis intercept mapping. So crisis intercept mapping is a particular process, but there are processes like this that can be done. So it doesn't necessarily have to be this specific process, but through this process, there is really good data that can be used to really like implement and improve, implement services and improve the crisis system locally and statewide. So when people were introducing themselves in the chat at the beginning, I was seeing different people that were there. And I saw some folks from New York, so I just wanted to give a shout out. I'm in New York. And I think that this is relevant for people that work at the state level, people that work in the local level, the community level, as well as kind of the federal level. And I think it would be like kind of different levels and layers of kind of like reviewing data and using that to really inform this particular work and what you would be doing moving forward. So I just wanted to start by saying that this particular project with crisis intercept mapping was worked through the SAMHSA Service Members, Veterans, and Their Families TA Center, or the SMVF TA Center. So we partnered with Policy Research Associates, otherwise known as PRA. So this particular work was initially focused on service members, veterans, and their families. But we realized that the information that we collected was relevant to the general population, not just service members, veterans, and their families. So as I'm presenting, you will see certain data that's specific to service members, veterans, and their families, and then some that's more general. So I'll point that out as I go through. Next slide. Okay, so through this, wanted to kind of align the what I'll be presenting on with the goals of this entire session on data. And I think just like I want to reiterate, underscore that crisis intercept mapping can be effectively leveraged to identify gaps within the crisis care infrastructure. Data collected during this can be used to look at quality and outcomes across communities. It's really discussions among key collaborators to address service gaps. And then this can also be standardized into an approach that can be used, in different communities and states, like I was saying a moment ago, to strengthen planning and delivery of services. Next slide. So what is crisis intercept mapping? So here I have the different elements that we're going to be focusing on throughout the presentation. So that's screening, safety planning, lethal means safety, and supportive contacts. As I go through the slides, you'll see these little kind of arrows or tabs at the top left that's pointing out to what is the particular intercept. So crisis intercept mapping there's 4 intercepts, and one of them is first contact. So that's kind of where the screening plays in. The second one is acute care, and there'll be a lot of focus on safety planning for that. The third one are care transitions. And the fourth one is ongoing treatment and recovery support. So what communities do in this process is there's a survey, community-based survey that these teams distribute, and it asks all these different questions about services and processes that are currently in place. And then they come together for workshops with the facilitator, and like an outside facilitator who then takes copious notes and really guides the conversation to identifying really what the challenges and gaps are, where there are opportunities, and then kind of leading them to brainstorm processes to move forward and to address the gaps and take advantage of these opportunities, essentially to come up with an implementation plan. Next slide. So what we did specifically in this we looked at 24 communities that were participating between 2020 and 2022. And you could see the kind of the where they were located, but they were all across the country. And so the TA sessions discussed, various different things, what the crisis care infrastructure looked like, the gaps at each intercept, plans for addressing the gaps, and then what are the best practices and resources that are available to communities so that they can address these gaps. Next slide. So we did 2 analyses here, and I wanted to point out a couple of things. So the quantitative analysis was with the Community Information Gathering Tool, or CIGT, which was administered to organizations prior to the TA sessions, and we had 272 organizations respond. So an individual responded on behalf of the organization to kind of say what they were doing with respect to mental health, suicide prevention, and crisis care. So the topics were touch points with veterans. So you'll see on the slides that a lot of the veteran-specific information is coming from this tool. Screening for suicide risk, training completion by type, suicide prevention protocols and service delivery, and then collaboration. So the interesting piece here that I wanted to point out is that these TA sessions were conducted, and there was a copious note taker, and we were able to, through a data use agreement, get access to all of these notes and use them and do a thematic analysis. So it was a wealth of information collected through a process that wasn't necessarily a data collection process. So there's this valuable data that can be had on many different levels. So we have 4 main themes: identify and screen, safety planning, lethal means safety, and supportive contacts. So I'm going to go through all of those in more detail and really point out what we found in this analysis of 24 communities. But I just want to kind of underscore the value to the folks that are on this call, that maybe you're at the state level, and this could be something that is an initiative implemented in communities within your state. And then together you can look at the data from the state and really have like a statewide approach that's informed in data. Next slide. Okay, so the findings that we had, and you'll see the CIGT, which is a survey, the findings there on the right, and then the workshop and thematic analysis was on the left. So you'll see that, so this is the first the intercept 1, first contact, identify and screen. 73% of organizations ask an identification question for veteran status. So this is important for organizations, healthcare organizations, to know if someone is a veteran so that they can provide specific services that are tailored and culturally appropriate for veterans. So you can see that there's still over a quarter that don't ask that question. 64%, so fewer screen for suicide risk. So clearly, not bad, but need for improvement. This is something that we hope in this field that is done universally. So on the left, this is something that was found among it's not necessarily just veterans. Um, Gaps and challenges, so lack of established and consistent protocol and identification and screening, and limited knowledge and confidence in using screening tools. And you'll see this is a theme for other things that we're working with and looking at and the data as well. So what can be done to address that? So the teams talked this over and they talked about developing a formalized process both within and across agencies that they work with, increasing education and training for providers so they feel more comfortable, and then improving coordination among veteran serving organizations. Next slide. So Intercept 2, acute care. So we're focusing here on safety planning first. 42% of organizations have a safety planning protocol in place for high-risk service members, veterans, and their families. So that's it's pretty low, and that's clearly room for improvement across the communities that participated. So going to the workshops and the discussion in the workshops, that was really found as an issue across the board. So it's not just that they don't have the protocol in place for service members, veterans, and their families, but they didn't have it in place really, for any population. So they had a lack of established and consistent protocol for safety planning. Again, they lacked the confidence among the providers and there was limited training. And there was a lack of a standard definition for safety planning. So this came up quite a bit. Like we were reading through the transcripts and the notes, and what was a safety plan was different. So it's hard to say what actually, for those who were doing safety planning, what that meant. Like there was some that were like trauma-informed plans and crisis plans, but it's not a safety plan for suicide prevention. And the safety plan for suicide prevention is very specific for suicide prevention. So what an individual would kind of populate on their safety plan would not be the same for a suicide specific safety plan as it would be kind of for any other kind of crisis plan. So that was a significant issue that kind of came out in this discussion, and the need for really having that standard definition and implementing a suicide specific safety plan. So what can be done? So one of the things that was discussed was training different types of professionals, not just the healthcare providers, on essentially what the safety plan is and what the process is, because they can then encourage use of that safety plan. Because oftentimes these professionals come in contact with individuals who might be at risk of suicide, might have a safety plan, and might benefit from a safety plan. So this includes law enforcement, justice system staff, and faith-based organizations. The other thing is ensuring that all parties are aware and agreeable of their roles in the safety plan. So this came up as an issue a few different times in the discussions. And the idea that in a safety plan, one lists different people and people have a role in that safety plan. And it's really important that they know that they're in that, what their role is, and that they would agree to this, because in a time of crisis, if someone needs to call upon a person in their plan and they don't know about it, or that it's not a good situation, like maybe they wouldn't have agreed to it, that could be a really dangerous situation. So that's part of the protocol that these communities are looking to implement and strengthen, as well as provide training to the providers who are implementing these safety plans. Next slide. Also, part of Intercept 2 in acute care is lethal means safety. So just kind of very briefly, we know that lethal means, having access to lethal means is a big risk factor for suicide. And being able to, for example, safely store firearms and not have that kind of at hand in a time of crisis is really important for suicide prevention. So what are the gaps and perceived obstacles? And one of the things, well, first, about 40% of organizations do offer lethal means safety counseling to service members, veterans, and their families. So that's still a significant percentage that doesn't do that. So what they said kind of across the board, there was a lack of training for providers. So one of the big ones is COM, or counseling on access to lethal means. And there was limited knowledge and understanding of the importance of firearms within the military and veteran populations. So we talk a lot about, being kind of culturally understanding of the, gun ownership and different populations that, gun ownership is really like part of that population and in the culture. So military and veteran populations, that's part of the culture. And there was like limited could be an area for improvement is kind of military and veteran cultural competency and really understanding those populations. So what does it mean to own a firearm and then to essentially take it away, which is kind of what the fear is among service members and veterans. Um, Also, specific policies that make service members, veterans, and their families hesitant to report firearms and participate in buyback or safe storage programs. So they don't want, like, if they report having them, like, will they not get them back and all of that. So there's all these different policies that make them hesitant to do this. So opportunities and solutions to raise awareness of this mindset and about firearms and how that kind of relates. And then also partnering with gun shops, ranges, and law enforcement agencies to implement these lethal means safety efforts. Next slide. So intercept 3 and 4, care transitions and ongoing support. So you'll see from the survey, 20% of organizations have a protocol in place to provide caring contacts to service members, veterans, and their families at risk of suicide. So this is like the lowest one so far. And caring contacts is really like a simple message of caring that gets sent out to the individual. It could be like a text message or an email or a postcard even, just a simple check-in with information about how they can get in touch. So the gaps in perceived obstacles. So there's just like across the board a lack of health system policies and protocols on the follow-up portion. And what came out quite a bit. So a lot of us are familiar with the zero suicide model, and there's 7 elements to it. And one of them is transition. So it's that transition of care. And organizations and participants, they talked about how it's already a lot. Like, we're implementing zero suicide, we're doing all these different elements, but we just can't do it all. So we just leave the transition element out. So the transition one is hard because it's going outside of your organization. So that's like they go with the lower hanging fruit. So that's the transition out of acute care is a very high risk period in terms of suicide prevention. So that is particularly problematic. So they talked about some opportunities and solutions, and they talked about forming partnerships and developing protocols that would facilitate follow-up care. And also helping all parties understand the guidance that's provided upon discharge. So there's like a lot of confusion about what happens at discharge, and being able to say, like, this is what's going to happen next, this will happen in a few days, and this will happen, in a couple of weeks, and having those appointments in place. Next slide. So again, another piece of intercepts 3 and 4 is referring and connecting to resources. So again, I'll just point out that this was not just service members, veterans, and their families, but other general population as well. There was a lack of communication between organizations, and that's not surprising. I think we all experience that in the healthcare system. And which led to difficulty implementing warm handoffs due to lack of protocols and administrative obstacles. So a lot of times, like, what you really want to see is an appointment get scheduled while the individual is still there, by the provider. But oftentimes it'll be like, well, you'll receive a call from this organization. They'll schedule an appointment, and that organization never calls. Or, here's a number, you can give it a call and make an appointment. So, like, that often that's more of a colder handoff. So there was a lot of difficulty with the warm handoff process. So they talked about developing standard policies and procedures for follow-up and improving communication lines between acute and follow-up care. And they were oftentimes not like familiar with all of the different organizations that it could be referral organizations in their communities. And I think that's another thing, is having more education and connection and building that network. Next slide. So through all of the intercepts, what's important is collaboration. And I want to highlight the information on the right side there, that which we found very interesting and not really that surprising, but an interesting way to like convey via data that there's a significant drop off in partnerships from intercepts 1 and 2, which is essentially what happens within one organization, to intercepts 3 and 4 when it kind of goes outside and the person is already kind of discharged or outside of the organization. You can see the average number of partnerships across the intercept. So intercept 1 and 2, you've got about 8. Intercepts 3 and 4, you have about 3. So it's a significant drop off. What they said would facilitate collaboration is having shared goals and dedication to preventing suicide. So a lot of the people, of course, at the table were really, passionate about the work that they're doing, and they, of course, have the shared goal and dedication. So they're also, because they're doing these workshops, they're kind of more like ready to jump in and do this work. So that was a real facilitator. And then the cross-agency communication is really important, including meetings and interconnected electronic health records. But they, of course, talked about significant obstacles to collaboration. As I mentioned a few minutes ago, lack of awareness of resources and services available in the community, working in silos, and then communication issues. So I think these are things that we all have experienced, and they make it difficult to effectively collaborate. Next slide. Okay, so we also looked at training across the 4 intercepts. And I just want to point out some of the data here on the right. About 50% of organizations agreed that limited knowledge among staff was an obstacle. And then about 63% agreed that training gaps were an obstacle for preventing suicide among high-risk service members, veterans, and their families. So this table is just kind of showing where the individuals thought that their organizations were stronger or needed improvement on specific training topics. So it's essentially the number of kind of communities really pointing high as a strength and kind of high as needing improvement. But I think I'm going to cue the next slide that there's more. I think the information is better on the next slide to really convey the training that is happening in these organizations. So these are, of course, are organizations that, again, they're motivated to do this work. They've applied to engage in crisis intercept mapping, and they were accepted to participate. And this is kind of what their training looks like and what staff have received. So I think, it's most effective maybe to look at the greater than 75% column, the one all the way on the right. So about half of organizations have more than 75% of their staff trained in mental health. About the same in suicide prevention. Big drop off in crisis intervention, about 34%. And then the lowest is lethal means counseling at 17%. And also, of course, if less than 25%, you even have about 20% in mental health, 24% in suicide prevention, 30% in crisis intervention, and 60% in lethal means counseling. So as you remember in the prior slide, they talked about how lack of training was a significant obstacle, and you can see that there is a lack of training in really key training topics. Next slide. Okay, so we pulled together some kind of broad recommendations. Of course, develop standard protocols, because we know that kind of coming up with something in a time of crisis or on a case-by-case basis can be challenging, and it leaves it up for interpretation among professionals. Suicide risk and suicide prevention, it's a very difficult topic, even for providers and mental health providers. They don't always have all the training necessary, and it can be scary. So having a standard protocol is really helpful in those situations. Provide training and technical assistance. So these topics, it's not just kind of one 1 hour module online, and that's it. Like there needs to be a recurring training and then support that follows that at least periodically. And then improving partnerships and collaboration. So this is really key. So what are different organizations' roles within the care continuum? We have all different types of organizations, and not just healthcare systems, community-based organizations, first responders, law enforcement, faith-based organizations, all of those types of organizations across the spectrum. They talked about resource inventory templates, so really to know what they have, what the organizations have at their fingertips to be able to share with individuals who are at risk of suicide. And then having information sharing protocols and memorandum of understanding or MOUs. Just having that so that because it is important to share and transfer information as one is discharged and then referred into outpatient care. So having to, repeat information over and over again is really not a good situation for individuals who are at risk. Um, and then, of course, engage in quality improvement. And this is another thing to point out with respect to data, is looking at the services that are being provided, look at what's being done well, look at what needs to be improved, where are the gaps in implementation, and how can those gaps be addressed. And it could be, something that's going on in the process that, in the workflow that can be addressed, or maybe it's a training need. So with that being said, this article was published in the kind of the more general focus, not because, as I was saying before, it's not all specifically related to service members, veterans, and their families. And then we get into in the article about what are the considerations for 988 with respect to what the crisis infrastructure is looking like across the country, as we relate it to the 24 communities that we worked with. So you can access the full text article as well as the abstract. Next slide. All right, so I want to thank you for your time, and I'm looking forward to the Q&A session. Hopefully I can answer your questions.
Thank you so much, Dr. Harris. I really appreciate your time and expertise in sharing the crisis intercept mapping and really walking us through how that collaborative effort helped communities identify areas in which you could target resources and act to ensure that services are available in a targeted way, but also across your communities. Next slide. So just as a kind of wrap up of what we've reflected on, we talked a bit about the importance, again, of data collection and analysis. Both presenters talked about the importance of using data to support quality improvement efforts and thinking through that, as well as thinking through how to allocate resources in an environment where resources are scarce, right? Data collection, analysis, and thinking about where the gaps lie in your communities allow you to steward your resources in a way to make the best impact in your systems with the resources that you have. We also talked about, understanding the capacity to implement, where there might be training needs, where there might be staffing needs, that sort of thing as well. Maintaining accountability, also engaging with policymakers. Carrie talked a bit about return on investment and how using data in that avenue helps kind of think through engaging with policymakers and decision makers that might help with thinking through sustainability and from a funding lens as well. The crisis intercept mapping allows data to be collected to assess the access of services, quality of services, as well as outcomes. And that collaboration piece that we talk about among key partners in a community to plan an approach to addressing gaps. I will say, as you're digesting this wealth of information that you had, I want you all to think about how you could apply this in your states, in your organizations, in your communities, and where a moment where you're feeling hesitancy or pause, reach out to the TTAC. We're going to put the link to the TTAC in the chat again. These are things that we could help you think about. We can help you think about what the strategy is for your communities, for your states, for your organizations, how to use data. We can think about connecting you to subject matter experts like Carrie and Dr. Harris that could help you think through the specific ways in which they've done this. So please feel free, reach out, even if you don't know what the question is, again, that you may have about it. If you feel that sense of hesitancy, feel a barrier coming up as you're thinking through, like, this is a great idea for us to do in our spaces, feel free to reach out and we can help you move along with it.